Hi, my name is Dr. Glenn Hurst. I'm a family practice physician from Minden, Iowa, and I've been doing a presentation around the state for the last month on Medicare for all, or actually on single-payer health systems. So I've been asked by a few people if I would put out a little video so that they can share it with their friends and other people who might be interested. And we'll just try to get an understanding of the language around the different models for national healthcare systems. First, we want to get an understanding of what's the difference between Medicare and Medicaid. Having a language that we all speak in the same way is useful, and it's frequently a problem that the two programs are blended together in a conversation, but they're actually very different programs. Medicare is a program for people who are age 65 or older. They're a federally run system. It covers specific things in 3 to 4 different parts. The first part would be Part A, Medicare. That's the part of Medicare that pays for hospitalization and skilled nursing care. That's rehab after hospitalization. It's important to distinguish that between long-term care and skilled care. Part B is the part of Medicare that covers your provider charges. So your physician, your physical therapist, those are people who are paid as part under the Part B section. Part D Medicare is the part that pays for prescriptions, and it's usually an option that a person can buy into from various different insurance providers that will cover the cost of a person's medications. Medicare does not cover things like long-term nursing care. It doesn't traditionally cover all medications, and it's not completely free. People pay a copay and a percentage of their charges in each billing category. There are supplements, which is that fourth part that we talk about, Medicare, which is a private product that people buy to cover those additional expenses, the copays, etc. Medicaid is state-run insurance, run by each state individually, and those products can vary widely across state lines. So in the state of Iowa, we see Medicaid primarily covering people who have low income, pregnant women, children without insurance, people with disability, and people in long-term care in the nursing home. This is a big departure from what Medicare covers because it really rolls some pieces together that are left out of a Medicare system. Dental, vision, hearing are often frequently covered under Medicaid plans as well. A state can administer its Medicaid plan pretty much however it would like, as long as it's covering the lives that are intended to be covered. In Iowa, we have straight Medicaid, which is a program that's administered by the state. That state Medicaid program is a very small portion of Iowa Medicaid. We have now contracted with private payers to manage Medicaid for our state, and that has been much to the chagrin of many people, as we've seen decreases in services provided, we've seen decreases in quality of care, we've seen decreases in care happening in a timely basis. So Medicare and Medicaid, two very different programs, two very different administrations. It's important to get an idea of how the whole system works together with our private insurance if we're going to have a discussion about a Medicare for all product or a single payer system. We talked about what Medicare and Medicaid do and different ways that those are managed. We also have private insurance, and private insurance would be your Blue Cross Blue Shield, United Healthcare's, Aetna's, etc., that you see commercials for on television. These companies will provide the payment to the various providers that they've agreed to pay, and they pay them in dollar amounts that each one of them negotiates with those providers. So that's why going to your physician is not like buying a loaf of bread. Your trip to the physician's office may be exactly the same as my neighbor's visit to the physician's office, but you pay X dollar and that friend pays Y dollars, and the two are very different fees, different numbers for almost the exact same level of service. That has to do with negotiations between payers and providers. This happens at the hospital level, the physical therapy level, the nursing home levels. All of these things are negotiated by each company. So there's a bureaucracy that goes with participating with each company, and a provider group spends hours upon hours upon hours of their week managing the bureaucracy of getting paid for their coverage. We like to think that we get to pick our provider, our physician, which we do for the most part. Usually a payer program has a list of physicians who are in-network, or they cover physicians at different rates depending on their quality. But the reality is your payer product, how your providers get paid and what is actually covered in your services, are packages that are brought to your employer, and your employer will pick from the hundreds of options for coverage and usually present to the employee, here are your two choices for coverage through our business. So we have the idea of choice. We have a slight choice in what we get in terms of a payer product, but the reality is all of that has been filtered through your employer first, and usually it has to do with what's the least expensive and yet will still be attractive to bringing in new employees to a business. You'll also see that people can buy into some of these payer products through their Medicare Advantage program. So that's a program for people who are over 65 who qualify for Medicare that don't want the state-managed product. They would like the private payer-managed product. And so Medicare will pay your premium into the payer, and that payer will tell you or negotiate with you what things they will cover. Sometimes that includes extended coverage for medications. It might include some dental and vision that aren't covered in a traditional Medicare. That's not where it ends in terms of how the money flows in healthcare. You have money that flows from the covered life, the individual through their employer into the payer pocket, which is then invested to raise more money, hopefully to cover services. But other people buy into insurance products as well, and those are private investors that invest in companies like State Farm, United, Blue Cross, with an intention of making money off of the health of the covered life and the administration of the money by the insurance company. So these insurance companies are now beholden to two types of investors. One is expecting a payout for health services, and the other is expecting growth of their investment. So you now have a company that's beholden to two masters, and the master that usually is given precedent is the investor. So the money flows from the investor and the covered life into the different provider services and back to the investors. So it's in the best interest of the insurance company to pay out as little as possible for the health coverage and pay out the most for the investors. The way they do this is by denials. They put their bureaucracy in action and they deny coverage for services that an individual needs. They make it difficult for those individuals to access the services that they need, and thus they keep the money within their investment pool. This is why we're ninth out of the top 10 developed countries in the world in terms of health quality and health outcomes. It's because we aren't taking care of people well with our current system. Medicare works similar to the way a private payer system works. They have a pay-in, but it's in the form of tax deductions taken from your paychecks throughout your working history. That money is pooled with all the rest of the working individuals in America and invested for the purpose of providing services once you reach the qualifying age. There aren't separate investors that are buying into Medicaid other than people who may not have worked enough years in the economy to qualify. Those people have to pay a premium to make up for that in order to be covered by Medicare. So the Medicare dollar goes to the providers directly, and usually that is through the straight Medicare program. There's a dollar amount set for how much Medicare will pay for services X, Y, or Z, and that's what's paid to all providers. Most private payers will set the rates that they reimburse based on Medicare. So you'll frequently hear insurance companies talk about, we pay 150% of Medicare, or we pay 90% of Medicare. That's the rate that they're discussing. So there's already a level of price fixing that's going on in the healthcare industry anyway, but there is some variation, as we said, as to which amount each payer is going to pay for which service. The managed Medicare product is a product that is your tax dollar that's been paid and invested going into a private payer, an Aetna, a Coventry, a Medicare Advantage program, which you can choose to enroll in once you're eligible for Medicare, and that provider then works just like a traditional insurance payer in what they cover and don't cover. Medicare has a little bit of a say in what services must absolutely be covered, but it gives them room to work with covered lives to give you the system that hopefully is best for you, the patient. So putting these payer goals on paper together, you've got payers who are part of the private industry that want to drive prices down and drive the dollars down, and they do that by denying services. It's usually the very first thing a payer will do when they receive a claim is just deny it outright without looking at it, in hopes that whoever is making the claim will find the process too frustrating and that they'll just let their fish back into the sea and not collect the money. This is a common practice when you're dealing with 10, 15, 25 different payers, and you've got one person who has a single contract with a payer and you've charged $100, but you've got another program that you have many, many enrolled lives in, and you've charged $100 a patient for 50 patients. Well, you're going to spend your time and money trying to collect that rather than the $100, and that's how they keep money in their coffer with an instant denial. Then, if you do appeal, there's hoop after hoop after hoop that you jump through in order to prove that you indeed provided the care and that you deserve to be paid for the service that you provided. On the Medicare side, or the government payment side, their goal is not so much to keep money from flowing out, but to make sure that they're paying for quality services. So when we receive denials from Medicare or Medicaid, it usually has to do with, was this medically necessary? And quality is a much bigger issue for our government systems than it tends to be in our private pay systems. The private pay systems will tell you that's not true, but when we're ninth out of the top 10 developed countries in health outcomes, it's clear that we're not meeting quality goals like other countries are. And all of those other countries are using some form of national health coverage or health system. And we'll get to the difference of what those two are. The differences between national health coverage and health systems are pretty dramatic. When we talk about Medicare for all, what we're really talking about is a single payer health system. Now, we've already discussed what Medicare does and doesn't do, so a Medicare for all would really just provide hospital coverage and doctor coverage for everybody, and it would still leave a lot of gaps: vision, dental, hearing, long-term care. But that's not what's being proposed by most of our presidential candidates. What's being proposed is actually a single payer system that expands Medicare to cover all of those things that Medicaid currently covers, as well as other things that are pertinent for the health of American citizens. So it's not just Medicare for all. It's an expanded system that would cover everybody from birth to death, and it would be paid for out of a tax deduction. The universal multi-payer health system is more like a insurance system that everybody is required to buy into and would require a certain level of care to be provided by every plan. A national health system takes us beyond a payer system into a provider system. In a national health system, your physicians and hospitals are owned and employed by the national government, and they are paid by the national government out of taxes that come from your paycheck. So it's a very different system beyond just how do we pay private individuals for the services that they provide. In a single payer system, health insurance is publicly administered and the physicians remain in a private practice, very different from the national health system we just discussed. We see this in a number of countries around the world: Canada, Denmark, Norway, Australia, Taiwan, Sweden. But you would also be able to make an argument that Medicare itself is an example of a single-payer system. It only applies to people who are age 65 or older, but that is the level of coverage that they get uniformly across the country. Medicaid is another example of a single-payer system for people who qualify for that product. This is being proposed and supported, obviously, by Bernie Sanders as part of the Medicaid or the Medicare for All Act. Again, kind of a misnomer because it's really a single payer for all act. But it also has the support of Booker, Buttigieg, Gillibrand, Harris, Messam, and Senator Warren. They're all co-sponsors of this Senate bill, but they're the ones that are in the Senate are. But they each have some little variation on how they would like to see it applied or what we should do in the interim as we move forward. And we'll talk a little bit about that. Because timing of implementing a program like this becomes pertinent. What do we do with people who have insurance that they like? What will happen to the insurance industry and the people who work in that industry are all valid questions around a single-payer system. In the single-payer system, think of it just like we talked about Medicare. You have covered lives that will pay in throughout their lifetime, and the government will administer and set rates with provider groups and the covered services as part of their oversight function. There are pros and cons to every one of these systems. This was a nice slide that I actually stole from another presentation that covers the sole provider or the sole payer system pretty well. We're looking at lowering the cost of healthcare in our economy. We pay billions of dollars more than any of the top 10 countries for healthcare, and we still rank 9th in our outcomes. So this would be an improvement in our economy and hopefully an improvement in quality. It does make a uniform payment system for physicians and other providers, and it drives quality as the driver in healthcare rather than quantity. And we certainly would see huge administrative savings on the part of the providers who are providing that service. What we should see is a decrease in the amount of time that a physician's office spends trying to bill and collect for the services provided, and an increased amount of time that providers are available to care for patients. The cons, forces healthy people to pay for others' medical care. Well, that's exactly how all insurance works. The idea for a private payer is to cover as many lives as possible that won't need any of the benefits. That way they can use that invested money to cover the needs of those people that they're supposed to take care of, or in most cases, to increase the return to their investors. There's a concern that people will not be as vested in their health care if they're not having to pay for it directly at the window. Of course, they pay for it through their payroll deductions. But the reality is, when we look at other countries, their quality is so much better than ours that the argument kind of falls flat. The last point on here about most universal health systems report long wait times for elective procedures. That really has to do with national health systems. You notice here the heading on this is pros and cons of universal health care. That's one type of universal health care, and it really doesn't apply to the sole provider model or the sole payer model. A universal multi-payer system is very similar to what we already had with the Affordable Care Act, or Obamacare as it was called. This is a government requirement to carry insurance with a level of service put as an expectation on the provider of that service. So you would be required to purchase insurance. There'd be a mandate for that. There could be government subsidy for those people who can't afford it, but everybody would have an insurance product, and you could buy a private product either through your employer, through the exchanges as we do now, or some other route, but everybody would be required to have coverage. In the countries where this takes place, we usually see a strict control on how much a payer can charge, and most of these payers are nonprofit, so you don't have investors that the payer is beholden to. Germany, France are both examples of this type of system, and the United States was for just a short period of time when we held the mandate for coverage on the Affordable Care Act. You'll see some of the same names that you saw on the Medicare for All list here, because this is a transition tool that many of our candidates are supporting using to make a transition to a single payer system. So Biden, Booker, Hickenlooper, Inslee, Klobuchar, O'Rourke, and Swalwell all have some level of support for this type of plan. John Delaney has a similar plan that leaves Medicare intact the way it is, and then develops a product for people who are age birth to 65. Again, giving you the options to buy in or to buy a government program as well. In the end, it's very, very similar to what the Affordable Care Act already was. I mentioned the public option, which is really what this would add to the traditional commercial model that would allow consumers to go directly into a government-sponsored program, not just through a portal, but to buy into a Medicaid product, a state product. A national health system is not one that's currently being proposed by any of the candidates, but this type of proposal is what I mentioned before, where it's not just about how we pay for healthcare, it's about how we provide it. So physicians and hospitals are employed or nonprofit contracted with the government to provide care. We have national health systems very successfully in the U.S. economy currently. All of your armed forces are covered by a armed forces health system. If you're a member of the armed forces, you and your family receive your medical care by employed physicians in facilities that are owned by the military, and there are certain levels of quality care that they're expected to provide to everybody in the service. The VA is another example of this. They own the hospital, they own the physicians, and they manage how those individuals get paid. Great Britain and Spain are examples of how this is done. So you might hear people talk about the systems there where people have longer wait times, and that's really the issue, is having enough physicians, enough facilities to provide all the care necessary in a timely manner while still controlling cost. There's some great resources out there to look at to stay on top of what's happening in the presidential campaigns and who's supporting what type of health system. And so I would direct you to go do a little Google search and find the Washington Post article on Medicare for All. It's online, and if you go to this page, you can hover your cursor over each presidential candidate, and it will give you information about exactly what type of system they support. There are several questions that each one was asked to answer, and you can hover over their image on each answer. There's also information taken from their actual stump speeches and public statements regarding how they would actually stand on these topics. So I definitely recommend the Washington Post Medicare for All article, and I hope that this was a good use of your time. Thanks for listening.